A warm welcome to one and all. I think everyone enjoyed, or in fact, were engrossed in the previous session. See, we went past the time, so that itself shows what the interest is from the whole group. So, something similar is what you're up for today. So, with that, I extend a warm welcome to Dr. Sunil Kumar, who is, as mentioned, he's the additional director of Palem India Trivandrum and also head of three departments, clinical services, academics, and research. And you all had an excellent input, knowledge with discussions. So without taking too much of the time, I hand it over to Dr. Sunil Kumar to take us through this session too.
Thank you, madam, and good afternoon, everybody. So we will go through the methadone, and I would request all of you. Am I audible?
Yes, yes, we can. You are audible, and we can see your slide also.
Okay. So I request all of you to be very interactive. Otherwise, the session will be boring. So, okay. So in the last class, we discussed step 3 opioids, morphine and fentanyl. But we have not discussed methadone, considering that it is a special opioid in the step 3 of WHO analgesic therapy. Okay. And we will be talking about what is the difference of methadone from other opioids. And many of you might have heard that methadone should not be used. It can cause this problem, that problem, and things like that. So we will put it in this way that what are the benefits of methadone and what are the risks, and then when we take a medical decision, we always weigh between the benefits and risk. And when we feel that okay, benefits are more, then I will go with that intervention. Okay, so we will also do that. Then, what are the monitoring parameters while we use methadone, and how frequently and how aggressively we need to do that. And another important factor is that we should clearly identify a subset of patients who would be benefited with methadone. So the appropriate candidates, and at last we will see how we can convert an opioid to methadone. Okay. So I would like to start this session with a patient story. This is a young lady, 30-year-old woman with history of having sarcoma. And in 2016, she had a small swelling in the sacral area. And that turned out to be having sarcoma, for which she received chemotherapy and radiotherapy. Then for almost 2 years, she was comfortable. But then again, she started to have pain on backs and legs. And with the advice of the oncologist, she took an MRI. And it showed that there is disease progression with extension from S1 vertebral body. And in addition, there is a compression of L5 and S1 nerve root. PET scan showed it, she has pleural metastasis. So this is the pain she is describing. You can see the pain chart. Where the pain starts at low back. She described it as burning as well as shooting. And there is some relief on lying down, but any movements increases the pain. So that the mobility is restricted and she is unable to stay. And she was staying on the first floor of a house, and she was literally on the bed because any pain, any movement aggravates pain. So she don't go anywhere. She don't move. So she was in severe trouble and distress. You can see the pain score, which is given in the body chart, and that's the pain score at rest. But at whenever she has movement, that will increase to 10 by 10. And you know that we cannot be lying down without any movement for a long time. So you can say that she is in severe pain almost all the time. So I just want to ask you, uh, for this patient, how do you treat the pain of the patient? I would like any of you to unmute and speak.
They are mentioning that your voice is echoing.
Are
Is
you
that
getting
for everyone? Because I don't feel it's that bad, but I don't know. We'll ask them. Please. Yes, they are telling. Okay. And that's what they are like. Some are telling no, some are telling yes.
In case somebody is using multiple devices in a single room, we will
They can
request
have
them
that.
to, yes,
Yes.
because it is
Okay.
clear from our end.
That's what I too felt, but we have to give the benefit of doubt to them. So what we'll do, we'll carry on for 5 more minutes. And as we mentioned, if you're doing having two devices in one area, that is just interference, physics interference, that's all. So if anything like that, please do that. And in like 5 or 10 minutes, someone type in the chat if it's still carrying on. Sripriya and myself will have an eye on it and then go forward. Is that okay? Carry on, Dr. Sunil. As we said, we will see and move forward.
Okay, so can any of you please unmute and speak?
Yeah, I think since she has not tried on any analgesics, we can start as the WHO step ladder. Start with step 1, NSAIDs, and then gradually see how she is. How the relief is. And since it is a sarcoma, I think there is a neuropathic component also involved where the action of adjuvants can help her out.
Okay, thank you, Dr. Kavita.
Thank you.
Yeah. Anybody else would like to comment? Yeah, okay.
Hello.
Yeah.
NSAID is plus the adjuvant for gabapentin or something.
And then gabapentin.
Okay. Dr. Shika says NSAIDs, paracetamol, gabapentin. Aroda says neuropathic pain. Yeah, suggest. I think she wanted to give opioids, gabapentin, and paracetamol. And Dr. Sandoshi says she will do investigations to know the extent of damage. Okay. So I told you this is the pain score at rest, but most of the time she is in severe pain. So what would be the source? We need to go to the step 3 of the beta analysis pattern, or even at least step 2. If you think okay, this patient doesn't have much pain. But I told you, this is the pain score at rest, and on any moment, the pain increases. So probably morphine should be given. So anyway, this patient was seen by somebody else, and she was started on tab morphine, and it was increased to 10 milligram per centisoil. Then she was given amitriptyline along with that. You can see the pain distribution. And from the quality of the pain, it is burning and shooting. This is the characteristic of neuropathic pain. And you can see the pain distribution also. It is mostly on the right lower limb. So that again indicates there is a neuroanatomical or neurodermatomal distribution. So it's and again the MRI is suggestive of compression of L5 and S1 nerve root. So that also again points towards neuropathic pain. So these are the indications that this patient should be started on adjuvant analysis. So the amitriptyline was increased up to 75 milligram HS. Then they started her on pregabalin and gradually titrated up to 150 milligram BD. Then dexamethasone, and this patient from 20 March to 23rd June, she was under the care of another palliative care physician, but there is no pain relief. So what would you do now?
So since this was a moderate intensity pain, 5 by 6, 5 by 10 or 6 by 10, is it wise to start morphine in the beginning or should we start with the class 2 only?
Okay, so that's why I told you that this patient's pain score, what is given is the pain at first, but the pain aggravates to 10 by 10 whenever she moves. So it is not easy for a person to be like a log on the bed. So she moves, keeps moving, and the pain is almost very severe almost all the time. And when she lies, um, lies or when she is at rest, then only the pain score is this much. So I would do with, if you say I will start with the tramadol, okay, you try it for 2 days and you need to come on to morphine. So she was started on morphine and there is no pain relief. So what would you do now?
Titrate the morphine up.
Sorry?
Do you titrate the morphine dose to the high side?
Yeah, yeah, that can be done. Anything else?
Add an NSAID.
Okay, so I'm not sure about the NSAIDs here because we know that the pain is mainly neuropathic pain and the dexamethasone will take care of the inflammation that is occurring around the nerve root. So NSAIDs may not be of benefit in this patient.
Can you offer
Doctor,
radiotherapy?
sorry?
Can we offer radiotherapy? Or to
Radiotherapy. Yeah, probably, but I think the oncologist did not offer radiotherapy. I'm not sure, probably because it may not be responsive. So that's why he has not offered. But anyway, somebody has mentioned methadone. But you need to see that this patient is from 2018 early, and actually methadone was available in India since 2018 for as an analgesic, and it was not available at many institutions, and even now it is not available in many institutions. And during 2018, I think only 1 or 2 institutions would have methadone. So methadone probably would not be a choice during 2018 for many institutions. And for this palliative care physician, he was an anesthesiologist. So what he did was he put an epidural analgesia. So he put him on epidural analgesia with ropiacaine and morphine. And initially, this patient had some pain relief for about 18 hours, but then pain started increasing. But even considering the mild pain relief, because that was precious for this patient, because she was suffering, and as I told you, she was unable to move on the bed. So they thought that they will continue with the epidural anesthesia, and they reinserted the epidural catheter at different sites and tried to maintain for almost 2 months. But you know that epidural catheter cannot be kept at a site for more days. There is chance of infection, and finally they decided that they will take it out, and they started her oral morphine, which was 20 milligram 4 hours.
So what
And
was the placement of epidural catheter since there was involvement of the L5 vertebra?
nerve root compression, L5 and S1.
Yes, there was involvement of L5 vertebral body also, you said.
Yeah.
So where was the epidural catheter placed?
Where did I do not know, because I am not the person who this was put by some other anesthesiologist, and this patient was not under our care. And then this was the history given by the patient. So probably maybe L2 or L3, I'm not sure. I don't know, even in the upper levels. But anyway, the epidural catheter was removed after 2 months, and then he started taking morphine. The morphine went up to 40 milligrams 4 hours and SOS. And he again restarted the heroin, amitriptyline, and pregabalin. There was no satisfactory pain relief, and the patient had delirium and myoclonus. So what would you do now?
Now we can go in for methadone, probably.
Yeah.
Since the patient is not responding to him, patient is maybe developing tolerance to morphine. So now methadone can be appropriate.
Okay. Dr. Sanup says epidural catheter has many uses to put steroids for pain relief due to neuropathy to add opioids. Yes. Yeah, there are many uses. But in this patient, they infused local anesthetic along with morphine through epidural catheter. Okay. So this was the time the patient came to us. And what we did was we plan to start her on methadone. So this was one of our early patients for whom we started methadone. And so when we looked at the literature, there were so many methods on how to start methadone for a patient. So there were 3 days each, that is 3 days, then rapid conversion stop and go method, ad libitum stop and go method, German method, outpatient titration. So these all are the methods described in literature. But we didn't know which one need to select. And the literature also do not advise which is superior. And even there was a systematic review which says nothing is superior. So there was no recommendation. But many people were using 3-day switch conversion method. And we also thought that we will try with 3-day switch or something equivalent to 3-day switch. So when you convert an opioid to another opioid, you always compare the potency of these opioids. So this was the equianalgesic conversion table available at that time for methadone. So whatever the patient is taking, whatever be the opioid the patient is taking, you have to convert it into oral morphine equivalent doses. So you can see the patient is taking less than 30 milligram per day of morphine, then the conversion ratio is 2:1. That is 30 divided by 2, that is 15 milligram of methadone. If the patient is taking 30 to 99 milligram of morphine, then the conversion ratio is 4:1. So somebody if taking 50 milligram of morphine, then divided by 4, so it's 12.5. And you can see more than 1000 milligram, it's 20:1. So we also uh, uh, took this equianalytic table and converted our patient's morphine into methadone. She was taking 40 milligram 4 hourly. So what is the total dose of morphine she was consuming? Forty milligram 4 hourly. What is the total dose?
Now we will give 40 milligram TDS methadone.
Okay. No. I was asking what is the total dose of morphine this
240.
patient was taking?
240.
240 milligram.
Yeah, that is, yeah. So it is 240, isn't it? So 240, and you can see it comes between 100 to 299. So the conversion ratio would be 8. So 240 divided by 8, that will be about 30 milligram. So that is something called the incomplete cross tolerance. So when you convert an opioid to another opioid, you need to use the full dose that you have converted, because different opioids have different activities on opioid receptors. So when you convert an opioid to another opioid, you would cut down 30%, and that's known as incomplete cross tolerance. So 30% incomplete cross tolerance. So 30% of 30 milligram is 9 milligram. So you have to reduce 9 milligram from the total dose of methadone, that is 30 milligram, minus 9, which will be equal to 21 milligram. Okay, so this is the dose that we are supposed to start for this patient. And I showed you many methods, and I told you many of the people were using 3-day switch. 3-day switch means on the first day of starting methadone, you would not start the total dose of methadone. Instead, you would use only 1/3 of the methadone. Okay, so first day you would add 1/3 of methadone and reduce the morphine by 1/3. And on the second day, you will increase the methadone to 2/3 and you will reduce the morphine by 2/3. And on the third day, you will give full dose of methadone. Then you will stop morphine. So that is known as 3-day switch. But as I told you, this was one of our earlier patients, and we were really afraid to start patients on methadone because we know it can produce many problems. We have had a few classes which describes the methadone's side effects, its interaction with other medication. It can increase QT in the room. So there are many things which we were afraid of. So you can see what we did. So instead of 3 days each, we actually took 2 weeks to convert the patient to full methadone. So on the first day, we actually added 1/3 of the methadone and reduced the morphine by 1/3. And by 3-4 days, the patient was able to sleep. And on the day 7, we added another 1/3. So it became 5 milligram TID of methadone and reduced the dose of morphine by 1/3. So it became 15 milligram. And on day 14, we gave full dose of methadone, whereas we stopped morphine. And this patient had excellent pain relief with methadone. So actually, after 14 days, she came to our OPD by walking. So that was one of our first experience with methadone. And this patient was on various things, morphine, adjuvant analgesics, epidural analgesia, which failed to give satisfactory pain relief. But methadone was able to give a good pain relief for her, and she was comfortable till her death. And why this patient had good pain relief? For that, we need to understand the methadone's pharmacology. So methadone is an isomer of S-methadone and R-methadone. And on which receptor does morphine act? Can anybody tell me? On which receptor morphine acts?
It is a complete agonist of mu receptor, as well as it acts on lambda receptors also. Hence, it addresses neuropathic pain too. It is a mu receptor agonist as well as lambda receptor antagonist.
Mu receptor.
Okay, it's mu receptor agonist. But you can see S-methadone and R-methadone it acts on all the opioid receptors as agonist, mu, kappa, and delta. Okay. So it acts on all the receptors as an agonist. In addition, it has NMDA antagonistic property. So it is an N-medyl D-aspartate receptor antagonist. And another NMDA antagonist, which is usually used, is what? Yeah, it's ketamine. So methadone also has NMDA antagonistic property. And it also inhibits the reuptake of noradrenaline and serotonin. So which other group of medication has this mechanism of action? Inhibition of reuptake of serotonin and noradrenaline. Anybody? Okay, Dr. Sandoshi says tapentadol, tramadol. Yes, you are right, but primarily that is the mechanism action of tricyclic antidepressants. Okay, so tramadol and tapentadol also has the same action, or it acts like tricyclic antidepressants as like also. So these are the three mechanisms by which methadone acts in our body. Okay, and these three are beneficial, but there is another action in our body, which is the blockade of human either agogo related gene channel. Okay, blockade of HERG or human either agogo related gene channel. Okay, and this gene is can be seen in smooth muscles, but abundant in myocardium. So when it blocks HERG, when methadone blocks human either agogo related gene channel, it can increase the QT interval, and which can lead on to torsade points and sudden death. So this is one of the side effects which everybody is afraid of. When we give methadone, are we going to produce torsade points and death of the patient? Okay.
Sir, I have a question. Since this patient was on 40 milligram morphine and we switched for earlier QID, and we switched on to methadone, do we need to continue with this amitriptyline or pregabalin which we were given, because methadone itself addresses neuropathic pain? So do we need to continue, or we just start only with methadone?
Okay, I think we are going to cover that question in the coming slides. Okay, so we will see what are the clinical impacts due to the action of methadone on receptors and other mechanisms. So due to the opioid receptor agonistic property, can produce analgesic effect. But you also know that when opioids act on opioid receptors, it will also produce the side effects like constipation, nausea, vomiting, all those problems. So that can also occur with methadone. And this is the impact due to NMDA and agonistic action of methadone. You can see here 4 patients, and on the x-axis, that is the dose of or morphine equivalent dose that patient is taking. So they are on opioid. When those opioids are converted into morphine, they are, one of them is taking about 1000 milligram, and another one is taking 2000 milligram. Then patient B is taking about 8000 milligram. Patient A is taking about 12,000 milligram of morphine. Okay. So why these patients are taking this much higher amount of morphine equivalents? And can anybody tell me what is tolerance? What is tolerance?
Increasing the dose.
Patient requests progressively increasing doses.
Sorry, I did not hear properly. Can you come again?
Hello, with the patient requests
dose,
progressively increasing doses.
Yeah, Dr. Chidananda. The patient needs more doses, for more dose of medicine to get the same.
For the same amount of pain
Yeah.
relief.
Yeah. So if you consider a patient with pain score of 10 by 10, and you give morphine 5 milligram, and the pain score came down to 2 by 10. But after a week, to get the same pain relief, you might need to increase it to 10 milligram. And after some time, you need to increase it to 15 milligram to get the pain score of 2 by 10. So to get the same effect, you need to increase the dose. So that's the simple explanation. To get the same effect, we need to increase the dose of medication. So why this? Probably these patients also have tolerance, and that's why they are consuming such high amount of morphine equivalents. And it is said that NMDA receptor is involved in the development of tolerance. Okay, so NMDA receptors are involved in the development of tolerance, and you can see this when all these patients are started on 30 milligram of methadone, regardless of the dose. So the patient who was taking 1000 milligram of morphine equivalent, as well as the patient who is taking 12,000 milligram of morphine equivalent, they all started on 30 milligram of methadone, and all these patients had good pain relief, which indicates that NMDA receptors are involved in the development of tolerance. So methadone is a good medication that can actually prevent and reverse the tolerance. Okay, so that's the effect due to NMDA antagonism, and it has additional analgesic effect in neuropathic pain. And next clinical impact is due to inhibition of reuptake of noradrenaline and serotonin. So we know that tricyclic antidepressants are the choice of medications for treating neuropathic pain. So methadone can also have a good effect in neuropathic pain. But there is another problem which can happen if you give methadone along with the following medications. So you can see if you give methadone with this medication, fluoxetine, sertraline, paroxetine, clomipramine, MAO inhibitors, there is high chance of producing serotonin syndrome, and medium chance with this group of medication, and low chance with the right hand side of medication. So this is not only the problem with the methadone, but if you think about tramadol or tapentadol, and if you give these medications, fluoxetine, sertraline, then also there's a chance of producing serotonin syndrome. Okay. So what is serotonin syndrome? Serotonin syndrome, it has a group of symptoms, and it is manifested by cognitive changes, autonomic instability, and neuromuscular changes. Suppose if your patient is taking methadone and you start him on amitriptyline or fluoxetine, and you see that patient is agitated, he has hypothermia, tachycardia, he has tremor, foveal rigidity, then you think whether can it be due to a serotonin syndrome. Okay, so just to keep in mind that this can be a problem, but this is a rare incident. Probably it can occur more with MAVA inhibitors, which the use of MAVA inhibitors, I think it is very decreased now. And the next action is due to action on human either agogo related channel. As I told you, it can increase the QT interval, which can lead on to tossed points and sudden death of the patient. Okay, so our patient, the patient with Ewing sarcoma, the young lady, she got good pain relief, probably due to the three beneficial effects of methadone. One is it acts on all the opioid receptors as an agonist. Then it acts as an NMD antagonist, and it inhibits the reuptake of noradrenaline and serotonin. We know that there are many risk factors for tossed points, and you can just see there are a lot, including the cancer, and particularly note that if the patient is taking higher amount of methadone, then the chance of tossed points are more. So they say that if you take more than 45 milligram of methadone per day, the chance of getting tossed points are more. But one thing you have to understand is that the tossed points, the studies on tossed points, those studies are done mostly on patients who are taking methadone for oral substitution therapy. So the methadone is used for two purposes. One is it is used as an analgesic, and the other one is that it is used as an oral substitution therapy for opioid dependence. Methadone was available in India even previously, but that was mainly for oral substitution therapy. And it was made available as an analgesic since 2018. And you can see this study, which was done by MD Anderson Cancer Center. And they recruited 100 cancer patients and started on methadone. But they monitored the ECG at the baseline, then after 2 weeks, 4 weeks, and 8 weeks. So what they found was no patients had greater than 25% of increase in corrected QT interval from the baseline. And there were no patients who had tossed points or ventricular fibrillation. And the median methadone dose was 23 milligram. So this is one study which says that if you use methadone in a low dose, then probably the patient might be safe. It may not cause any tossed points. And there is a list of medications which can actually increase the QT interval and can toss the points when taken along with methadone. And if you note that the level of risk on the left-hand side, those medications are commonly used by palliative care physicians. You can see ciprofloxacin, azithromycin, fluoroquinolones and macrolide antibiotics. Then citalopram, haloperidol, escitalopram, fluoxetine, ondansetron. So those all are commonly used. And many of these medications on the right hand side are commonly used by palliative care. So whenever you prescribe methadone, you have to see what are the medications that patient is taking. So on this, we already saw, and we are moving on to pharmacokinetics. Methadone is also absorbed orally, and but in contrast to morphine, methadone can be given sublingually, and 30 to 36% is the bioavailability after sublingual administration. But morphine is not recommended to be administered sublingually. So that's one thing which you have to know. And parenterally also, methadone can be administered. We have only oral formulations in India, but injections are available outside outside countries. Then when you take a methadone for the first time, what happens is that for the first 2 to 4 hours, methadone will be available in the plasma. But immediately after 2 to 4 hours, the methadone will be disappearing into tissue binding sites. And these tissue binding sites are mainly in brain, GIT, kidney, liver, muscles, and lungs. So all the methadones you have given will go into the tissue binding sites. And once the tissue binding sites saturated, then only methadone will be liberated into the systemic circulation. So you can see this. The tissue binding sites are saturated with methadone. Here it's saturated so that some of the methadone, a fraction of methadone will be liberated into the systemic circulation. Then only you will get stable pain relief or consistent pain relief. So for this process to occur, it will take about 5 to 7 days. So what is your inference from this? What is your inference?
Methadone is long acting.
Yes. Anything else? Yes, let's get that.
Bioavailability is quite more.
Sorry?
It has a high oral bioavailability.
Low by oral, with oral low bioavailability.
Okay. So methadone gives pain relief. When you administer methadone for the first time, it will take about 5 to 7 days to get a stable pain relief. That means you should not increase the dose of methadone till 5 to 7 days. But in case of morphine, you can increase the dose every day. But methadone is not like that. And that is one of the most important difference between morphine and methadone. If a patient has acute severe pain, you can give morphine and a patient can get immediate pain relief. But if you give methadone, it will take 5 to 7 days to have good pain relief. So methadone is a not good medication in acute severe pain. Okay. And methadone is metabolized in liver. So we should be careful in case of severe hepatic dysfunction. And you can see it is metabolized through cytochrome P enzyme system. And there are many cytochrome P involved in the metabolism of methadone. And we also know that there are many other medications which are metabolized by the same cytochrome P enzyme system. So That means there can be some interaction between methadone and the medications. So this is another thing which you need to be careful. So this can either increase the dose of or increase the methadone level in the blood, or can decrease the methadone level in. So that's the importance. So you can see these are some of the examples of cytochrome P inhibitors. So grapefruit, protease inhibitors. What are protease inhibitors? Anybody? What are protease inhibitors? Okay, yeah, I can see some of the comments. Yeah, these are antiretroviral medications. Okay, then as well antifungals. We know that in palliative care we use lot of fluconazole because these patients are already immunocompromised and they can have reflux. So as well antifungals like fluconazole, ketoconazole, they can have drug interaction. Then cyclosporin, cimetidine, macrolide antibiotics, and then amiodarone and dronedarone, non-dihydropyridine calcium channel blockers like diltiazem and verapamil. So all these can have drug interactions because of the cytochrome P enzyme system. And as these are cytochrome P inhibitors, which can increase the methadone levels in the blood. So if you plan to start these medications with methadone, then it is recommended that you should decrease the dose of methadone by 25%. Okay. Otherwise, you have to start on or you have to find other alternatives. Instead of macrolide, would it be appropriate to start patient on amoxicillin, something like that? Then there are cytochrome P inducers like phenytoin, then phenobarbital, oxcarbazepine, rifampicin, carbamazepine, St. John's wort. All these will lead to reduced dose of methadone in the blood. So previously the patient who had good pain relief, and when you start patient on phenytoin, the patient can have more pain. So these are something which you have to keep in mind. These are not the only medication which are cytochrome inhibitors or inducers. There are a lot of other medications which can cause cytochrome inhibition as well as injection. And these are the list. I'm not reading this. Just to keep in your mind, there are a lot of medications. Probably you can take a copy of this and paste it in the nursing session. So that when you start a patient on methadone, you can just go through this and see whether the patient is having any of these medications. And how is morphine excreted from the body? Anybody? How is morphine excreted from the body?
By its metabolites, glucuronidation, morphine's glucuronide, and which also has some active metabolite component.
Okay. So that's metabolism. How it is excreted?
Yeah, after once it's glucuronidation, then it's excreted to the renal system.
Okay. So morphine is excreted mainly by renal route, and that's why it is not a suitable medication when the patient has chronic kidney disease. But methadone is mainly excreted through bowel. Okay. So methadone can be used safely in patients who have CKD. Okay, so if you have methadone and if the patient has CKD, then probably you can use methadone. What is the duration of action of methadone? It is about 8 to 12 hours. So you need to give it only TID or BD. But what is the duration of action of morphine?
About 2 to 4 hours oral.
4 to 6 hours.
Yeah. So yeah, but we give it every 4 hourly. So you can say, but anyway, compared to a methadone, morphine has to be given very frequently. We give it every 4 hours, but methadone need to be given only DD or TID. So now we are moving on to who are the appropriate patients.
Can-
Who are the appropriate patient to start on methadone? So methadone can be used as an adjunct. So that means, suppose a patient who is on morphine, 10 milligrams 4 hourly, and SOS. This patient is having very good pain relief most of the time, but he is waking up at midnight due to pain. So if you start this patient on a small dose of methadone, maybe 2.5 milligram, then this patient can have good pain relief, most probably. And so if you start a patient on small dose of methadone along with other opioid, it is described as an adjunct in the literature. Okay, so that is one indication. And the other one is you might be using or giving morphine, fentanyl, buprenorphine, many opiates, but still the patient doesn't have pain relief. That then you can call it as pain refractory to other opiates. So that's another indication. Then patient with a significant renal impairment and is in pain. Then need for a long-acting opioid, because we know that the duration of action of methadone is 8 to 12 hours. And we already talked about high opioid tolerance, the patient on 1000 milligram and 2000 milligram of oral morphine. And when we started the patient on methadone, they had very good pain relief. So high opioid tolerance, or there is a rare condition called opioid-induced hyperalgesia. Opioids can produce hyperalgesia in very rare patients. So if that occurs, then also methadone is choice. Then if the patient has poorly controlled opioid-induced adverse effects, suppose the patient has delirium, myoclonus with morphine, then you can start the patient on methadone. Then through morphine allergy. Some patients are allergic to some opioids, but in that case, you can start the patient on methadone. And patients with complex neuropathic pain. So these are the indications to start the patient on methadone. And there are some inappropriate candidates also. So there is, we know that methadone can, sorry, methadone can increase the QT interval. So if the patient or family, if there is a congenital QT syndrome, or if there is a family history of sudden unexplained death in the family, because the congenital QT syndrome can run in family, then probably methadone should not be started for those patients. If the corrected QT interval is more than 500 milliseconds, what is the normal corrected QT interval? Less than 450.
Less than 300.
Okay, yeah. In males, the corrected QT interval is up to 450 and in females up to 460 milliseconds. So if the corrected QT interval is more than 500 milliseconds, then it's a contraindication to start on metronome. And if the patient is unable to give us the feedback about pain, if suppose the patient has dementia and he is unable to communicate to us regarding the pain, then probably we should not start patient on methadone. And also another indication is that that should be a reliable caregiver to administer methadone. So if the patient do not have a reliable caregiver, do not start patient on methadone. Then if we are unable to follow up the patient, and as I told you earlier, acute pain crisis is not an indication to start the patient on methadone. Somebody has unmuted. Can you please mute? Okay, and now how should we monitor the patient when the patient is on methadone? So the most important thing is that if the patient is taking any curative treatment, then we should closely monitor patient and should aggressively investigate. But if the patient is taking only comfort care, then the need of investigation as well as monitoring would be less. So basically what you need to do is you have to do an ECG to find out the corrected QT interval and electrolytes, calcium, potassium, and magnesium. Because if these electrolytes are reduced, hypokalemia, hypomagnesemia, hypocalcemia, all these can lead to increased QT interval. So these are the some investigations that you need to do. And you have to follow up the patient with an ECG after 2 to 4 weeks of initiation of methadone. And when the methadone, suppose you started patient on a 2.5 milligram BD methadone, and when the dose reaches to 30 to 40 milligram, you have to again do an ECG and find out the QT interval. Then when the patient reaches 100 milligram. Another important thing is that I told you that methadone will take about 5 to 7 days for getting a stable concentration for steady state in the blood. But if the patient is elderly and if the patient is having impaired liver function, then it will take longer time, about 10 to 14 days. So you have to wait for 10 to 14 days if the patient is an elderly or if the patient has hepatic impairment. So this is the, yeah.
In your previous slide, you have written KCG monitoring 2 to 4 weeks when the methadone doses 30 to 40 milligram per day and 100 milligram per day.
Yeah.
What does this mean?
That means you have to do an ECG when the patient dose reaches to 30 to 40 milligram per day, and when now the patient is on 30 to 40 milligram per day, but if you increase the dose and it reaches 100 milligram per day, then you have to do another ECG.
Okay, thank you. Okay,
so this is the preparation available for us in India, which is known as RMED. The strength is 5 milligram, both tablet as well as syrup. Syrup 1 ml contains 5 milligram. Okay, injection is not available in India. And now we are moving on to conversions. So and the first line, methadone doesn't have a linear conversion ratio. And that means, suppose a patient is on 100 milligram of tramadol, and you want to convert this patient to morphine. What would be the equivalent morphine dosage? 100 milligram of tramadol you should convert it to equivalent dose of morphine. What would be the equivalent dose of morphine? Anybody?
Oh, okay, okay. 10 milligram. 100 milligram tramadol is equivalent to 10 milligram of morphine.
Okay. So that means methadone, tramadol is 1/10 less potent as morphine. So that's how she has calculated. Total dose of tramadol 100 divided by 10. So that will be equal to 10 milligram of morphine. So 200 milligram of tramadol will be equal to 20 milligram, and 300 milligram of tramadol will be equal to 30 milligram. But this type of linear conversion is not applicable in case of methadone. It varies, its potency varies depending on the dose of morphine, and that I will show you here. So this is the conversion method which we use now. So I showed you previously a conversion method which was available during that time, 2018. But we no more use that conversion table. And this is very simple conversion table and very conventional doses are used here. Okay. So according, this is a article came in Journal of Pain and Symptom Management in 2019, which is known as Hospice and Palliative Care Physicians Consensus Method for methadone. And according to this, if the patient is opioid naive, and if the patient is taking less than 60 milligram of oral morphine per day, which is considered as opioid naive. Okay. And in that case, you can start this patient on 2 milligram to 7.5 milligram of methadone per day. If the patient is taking less than 60 milligram of oral morphine equivalent. If the patient is taking 60 to 199 milligram of oral morphine, and if the patient is less than 65 years old, the conversion ratio is 10:1. Suppose the patient is taking 100 milligram of oral morphine equivalent. So the equivalent methadone would be 100 divided by 10. That is 10 milligram. And the next one, if the patient is taking more than or equal to 200 milligram of oral morphine equivalent per day, or if the patient is more than 65 years old, the conversion ratio is 20:1. So this is very simple to remember, but the previous one which I showed you in the beginning is very complicated. Okay, so please keep it in your mind. And how can you increase the dose of methadone? So if the patient is taking less than 30 milligram per day, you can only increase 5 milligrams of methadone per day. So that means, suppose the patient is taking 30 milligram and you see that patient doesn't have proper pain relief. So you can add 5 milligram. But once you add, then you have to wait for another 5 to 7 days before the increase. And if the patient is taking more than 30 milligrams, then you can add 10 milligrams. So this is the this is how you can titrate the dose of methadone. And now we will move on to some practical problems, real life patient experience. This is a 37-year-old man with carcinoma of the buccal mucosa. Hello?
Should we increase it per day or per 10 day?
So once you increase the dose, you have to wait for 5 to 7 days. It is not every day.
Okay, so previous slide.
Yeah. So this patient was diagnosed with the carcinoma of the buccal mucosa, but along with that, he had another second primary papillary carcinoma of the thyroid, and he underwent surgery and radiation. But in 2019, he had a level 2 nodal recurrence for which he underwent surgery. And Then he started to have pain. You can see the patient, how he is sitting, how severe his pain would be. So he complains of pain which start inside the left ear, going to the lateral side of forehead, then to submental region, and he described it as a pricking pain. So you can see the pink area in this face, which is the area of mandibular nerve distribution. And because of this, the treating team did an extraoral mandibular nerve blocks, and there were no pain relief. They did it thrice. The patient didn't had any pain relief. And then they gave him injection morphine, but it produced toxicities. Then they started him on tablet morphine like this 10, 15, 10, and 30. It's only 4 times with 10 milligram SIS. And even the dose you can see, they have trying to titrate it to reduce the toxicities. So probably that's why this patient was on morphine 4 times. And they also tried him on various adjuvants. And this is the prescription that patient is having. Tab morphine, pantoprazole 40 milligram OD, ciprofloxacin 500 milligram BD, escitalopram 10 milligram BD, serratiopeptidase, diclofenac patch 1 every day, then tab paracetamol 650 milligram on a cell. Suppose you are going to start this patient on methadone. What are the indications to start this patient on methadone?
First, this patient is already in ciprofloxacin and escitalopram, which need to be considered, which can lead to complications like the prolonged QT syndrome. They need to be substituted or stopped before we introduce methadone.
Yes, very good, Dr. Chidananda. What are the indications to start this patient on methadone? Anybody?
He's already tolerant to morphine, multiple doses, plus also with injection, he had toxicities. So that itself acts as a major indication for to start methadone. The dosages which is received and associated toxicity. So they're not able to increase the morphine dosage further. So we need to offer alternative play therapy for him.
Okay, I can see there are 2 comments in the chat. One is by Dr. Arora. One indication is neuropathic pain, and Dr. Burnama says morphine toxicity and complex neuropathic pain. Yeah, you are right. And you can also say probably it is refractory to opioids. So complex neuropathic pain, morphine toxicities, and not responding to other opioids. So this patient was on tramadol previously, then gave him morphine. It's not responding. Okay. So these are the 3 indications to start the patient on methadone. Before starting, what all should we do? So you are going to start the patient on methadone. What all questions should we ask?
Age of the patient, what all medications he's having.
History of sudden death in family.
Yeah, history of sudden unexplained death in family. Yes, that's one thing. Good.
History of arrhythmias.
Okay. Yeah. So,
Renal function.
renal function is not a problem here because methadone is excreted mainly in the through bowel. So renal function may not be a problem in that case, but electrolytes is something which you need to consider. The patient should have a reliable caregiver and ECG, then electrolytes. So electrolyte, calcium, potassium, and magnesium. And any concerns with present medication? Dr. Siddhananda already told ciprofloxacin and citalopram. Any other medication have interaction with methadone?
Pantoprazole.
Yeah, pantoprazole have some interaction with methadone. Yeah. So, citalopram, pantoprazole, and ciprofloxacin. So, can anybody calculate the dose of methadone for this patient? What will be the total dose of methadone required for this patient? Please calculate.
Take Charles Mentali.
About 5 milligrams twice daily.
$15 milligrams.
So should be around 6.5. So 2.5 thrice daily.
Okay. Can somebody tell me how did you reach to that dose? What is the conversion factor that you have applied?
So it's above 60 mg. So we are at 10:1.
Yeah. Yes. So this patient is taking total 65 milligrams, isn't it? 30, 10 plus 10, 50 plus 15, that is 65. So the total dose would be, what would be the total dose?
Total dose would be about 6.5 milligrams.
Yeah,
Since is already tolerant to this thing,
0.5 minus 30%.
yeah. So that's what I told you. When we were using the previous issue analysis table, we were using incomplete cross tolerance. But the newest method, you need not apply anything for incomplete cross tolerance. This is very conventional doses. So that's why I told you this is a very simple method. There is no complication method. So we need not do anything for incomplete cross tolerance. And whatever you have got after the conversion, that you can taking. Okay. So its conversion factor is 1/10. So the total dose would be 6.5 milligrams. And if you have only tablet, then you need to start the patient on probably 5 milligram half daily. But if you have syrup, then syrup methadone 3 milligram daily can be started. But we also told that when you start a patient for the first time on methadone, it will take how many days to give pain relief?
5 to 7 days.
Yeah, 5 to 7
because
days.
of the
Yeah. So, we
So-
also need to give morphine along with methadone. So this patient was taking 65 milligram of morphine. So you can say it is approximately 10 milligram Q4H, isn't it? And methadone, morphine is not given 4 hourly. Here you can see tab morphine 10 milligram Q4H on an SOS basis. If you prescribe morphine alone, then you would write tab morphine 10 milligram Q4H and SOS. Here it is 10 milligram Q4H SOS. That means, suppose a patient you give methadone 2.5 milligram in the morning, and at that time you will ask the patient, "Do you have pain?" Patient says, "Yes, I have pain." So you will give tab morphine 10 milligram. Then again at 10 a.m. you will go and ask the patient, "Do you have pain?" Patient says, "No, I do not have pain." Don't want to give morphine then. At 2 p.m. you will again ask. Patient says, "No, I don't have pain." Do not give. 6 p.m. patient says, "Yes, I have pain." Give morphine. So that's what 10 milligram Q4 exercise means. So this is how you have to give morphine along with methadone. So the prescription would be.
Hello.
Yes.
I just wanted to see, since the methadone takes a longer time for it for the serum levels for to achieve the pharmacological action. How
Mm.
about giving a loading dose and then coming down for the maintenance dose? Is that possible?
There are various methods that have been tried, but the one which is described by this white paper consensus method, which I just talked, doesn't advise to give loading dose. So I showed you earlier many other methods. In that, some advises loading dose, even some advises exercise dose of methadone, which seems to be not a good method for many palliative care physicians. So they have come to this considering many factors. So loading dose is not given. So this is how the prescription will look like now. Tab methadone 2.5 milligram daily, morphine 10 milligram Q for exercise, paracetamol 750 milligram. Instead of acetylcholine, he was put on amoxicillin 500 milligram PID. Then along with that, bisacodyl. So you have to remember to prescribe stimulant laxative along with the opioid. And this patient, this is a real patient. When he came to our IP, we thought that he will never get pain relief because he was in such a severe distressing pain. But to our surprise, within 3 to 5 days, he had very good pain relief, and he continued to have that pain relief till his death. Okay, now we'll move on to another patient. So this is a 39-year-old woman who is diagnosed with the carcinoma of the pancreas, stage 4, with liver, lung, and splenic metastasis. And she received 5 cycles of chemotherapy, but the disease was progressing. And because of that, they stopped the chemotherapy. And then she was on palliative care for comfort care. And her main problem was pain. You can see the pain description. It starts on the left lateral chest and abdomen, which goes on to the back. And mostly the pain is 10 by 10, which reduces to 8 by 10 when she takes morphine, tramadol, and paracetamol. And she was taking many medication from an oncologist, and she was on the following medication like morphine 20 milligram 6 hourly, injection tramadol 100 milligram IV TID, paracetamol 1 gram 6 hourly IV, tab gabapentin 100 milligram PID, amitriptyline 25 milligram HS, bisacodyl 5 milligram 2 HS. And even with this, she had frequent myoclonus. So are there any indication to start a patient on methadone? Or what are the indications to start this patient on methadone?
Pain intensity is high and morphine and opioid requirement is also high.
Okay. Can anybody else comment on what are the indications?
Resistant pain. She's on morphine 20 milligrams Q6 hourly, plus the second line of medication like tramadol, gabapentin, amitriptyline, everything, and paracetamol also. Despite that, if she's having pain,
I can see neuropathic pain.
despite that, if she's having pain, then she needs to have a alternative line of management.
Yeah.
Because almost all possible medications are being tried and the pain is not, she does not have adequate pain relief.
Okay. So the indication again are opioid toxicities. The patient has myoclonus, then neuropathic pain, and refractory to tramadol as well as morphine. So these are the indications. So what are the investigations you should do? ECG, calcium, potassium, and magnesium. Actually, this patient is getting only comfort care, and if you see a patient like this and you are unable to do an ECG and electrolytes, then it should not be a hindrance to start this patient on metformin because he is receiving only comfort care. The goal of care is not curative. So, if possible, do a baseline ECG, calcium, potassium, and magnesium. Even otherwise, you start the patient on methadone. So, what is the dose of methadone in this patient should need? So, these are the medications. I will give you 1 minute to calculate.
But tramadol also, then it becomes about 440, 120 milligram of morphine equivalents. He is already she is already taking.
Okay, anybody else? I can see some in the chat.
Sixty minus.
Okay, let's see. So this patient is taking morphine 20 milligram 6 hours. So it will come to 80 milligram of morphine. But you also need to convert tramadol to equivalent dose of morphine. So all the opioids you have to convert to oral morphine equivalents. So she is taking 300 milligram of tramadol, which would be equivalent to 30 milligram of morphine. So 80 plus 30, that would be 110 milligram. And here the age of the patient is 39, and she is taking morphine 110 milligram, which is in between 60 to 199. So the conversion ratio is 10:1. So it is 11 milligram of methadone. So you can start with methadone 5 milligram BD. Any concerns with the present medication?
Amitriptyline was moderate.
Okay.
Not
Yeah,
nortriptyline can be switched over to nortriptyline.
okay. Yeah, that's very valid point. Here, the patient is on amitriptyline. So amitriptyline has some interaction with methadone, but the dose of amitriptyline is 25 milligram. It's very low, so it may not have much interaction. So either you can stop it, or you can just allow to continue. So this patient was started on methadone 5 milligram BD, and then tab morphine 20 milligram Q4X on SIF basis. Paracetamol, gabapentin, and amitriptyline continued. And this patient again, she was a nurse who was suffering with this severe pain and was unable to come out of her house. She had two kids, and a husband, and she was always in always sad because she was unable to do anything for her kids. But after starting methadone, she had very good pain relief, excellent pain relief, and she could attend the first Holy Communion of her children. And she was very much active after starting methadone. And the time till her death, she was having very good pain relief. So this is another case.
So over here, since it's a neuropathic pain, they could have even stepped up gabapentin to the maximum doses.
Yeah, that can be done, but you can see it will take time to step up to the recommended dose of gabapentin. What is the recommended dose of gabapentin? It is up to 3,600 milligrams, that is 3.6 gram per day, which will take long time. So till that time, even we do not cannot say that even if the patient is on optimal dose of gabapentin and amitriptyline, will she get a good pain relief? We cannot answer that now. But one thing is sure that it will take long time to step up the dose and to have it optimal dose. So we should not allow the patient to suffer when the patient is coming to us. So we thought this is a patient who is a suitable candidate to start on methadone. So within 3 days, the patient will have very good benefit, and 5 to 7 days, the patient has excellent benefit. So that's how the methadone benefited her.
But once you start on methadone, will you be able to reduce it and continue without methadone?
I didn't get you, Sunil.
Once you start methadone for this neuropathic pain, will you be able to reduce the dose and after that continue without methadone?
We have not tried because you know that the cost of gabapentin and pregabalin compared to methadone is very high. Methadone for 3,600 milligram. What would be the cost of gabapentin for 3.6 gram? Maybe I don't know, maybe up to 200, 300 rupees per day. But methadone would cost only probably 5 milligram BD. So that means 5 rupees per day would be the cost of methadone compared to gabapentin. So I would not try to reduce the methadone and increase the gabapentin. I will continue to use methadone because we know that methadone is already effective for this patient and effective from the point of view of pain as well as from the point of price. And we do not know if we increase the gabapentin, will it give good pain relief? Not sure. So this is another patient. So this patient is a dummy patient, and just for calculating the dose of methadone. So this is the patient who is taking morphine 40 milligram Q for a cendazole, 40-year-old man, no pain relief. Suppose you want to start this patient on methadone, what would be the starting dose of methadone? Anybody?
12 mg.
Okay, I can see Dr. Arnold also says 12 mg. Yes. Okay. So what is the total dose of morphine? He's taking 240 milligrams. So if the dose of morphine is more than 200, then the conversion factor would be 20. Okay. So 240 divided by 12, that would be 12 milligram. So I hope you got something, or you understood the conversion of an opioid to methadone. So that's why I use this patient story. And these are some websites you can check for cytochrome P interaction and as well as QT prevention medication. And I would like to tell you that when previously methadone was available in 2018, we started methadone only for some 5 patients in a year, in that year. But next year we started methadone for about 20 patients, and thereafter we are using methadone more freely. When I talked about the interactions and QT prolongation, dosage points, then you might also have this fear of starting methadone. But please understand that when you use methadone in doses lesser than 40 milligram per day, the chance of getting dosage points and prolonged QT interval is very, very less. And be aware of the drug interaction. Whenever you prescribe medications along with the methadone, make it very simple. Do not prescribe too many medications. Polypharmacy should be avoided, because if there is polypharmacy, then definitely there are going to be some interaction with methadone. And all of you, I would encourage you to start patients on methadone. And I know many of you will not have methadone in your institution, but if you have RMI status, then you can actually stop and dispense methadone with the same RMI. So you need to respect methadone, but don't fear to start patient on methadone. Thank you.
So what is your experience with failed methadone cases?
So I should say that almost 95% of patients for whom we started on methadone has very good pain relief. So I think the most important thing is that you have to select the patients for methadone. That's the most important thing. And 1 or 2 patients for whom we started methadone, we stopped it after a few days. One patient because there was no reliable caregiver. Other patient was giving inconsistent pain scores, so we were unable to actually understand the pain of the patient. So those are the 2 patients for whom we started on methadone and then later stopped after a few days.
After stopping after a few days, what did you continue for them?
Those 2 patients had neuropathic pain. So we started, we gave them adjuvants, but the pain relief was not good on adjuvants.
Dr.
So
Sunil, my question still remains unanswered. Okay, when you switch over to methadone, we still continue with this tricyclic antidepressants and other adjuvants, gabapentins and all that? Or why don't we come down with the drug? Because the neuropathic pain part is covered by methadone. So should we come down with it or we continue in the same dose?
So if the patient is on high dose of amitriptyline, then we usually reduce the dose and gradually taper and stop.
And what is
Otherwise, we need to continue with it.
It is better to reduce and stop, because I told you amitriptyline has interactions with methadone.
Thank you.
And what is your experience for using methadone in non-neuropathic pain?
I think it is also beneficial in non-neuropathic pains. And I would say that if the patient is on high amount of morphine and no pain relief, then better to try the patient on methadone.
If the patient starts, if the pain is reappearing after methadone, what should we do next?
I couldn't understand.
If the patient was having pain relief with methadone initially, and we increase the dose, pain started appearing again, we increase the dose of methadone, and methadone dose is increasing and increasing. Can we go back to morphine or continue with methadone?
Okay, I would increase the dose of methadone with SOS doses of morphine.
No, he said you increase the dose, but see, initially, that's what I understood. Initially, you start on methadone, patient had some relief, then started telling about more pain. So they started increasing, they go up on methadone, but then no pain relief. So in that case, will you go back to morphine? That was the question. Am I right?
Yes, ma'am. Yes, ma'am.
That
Exactly.
is what he asked.
No, I think whenever the patient comes, each time we have to reassess the pain, the type of pain, and is that the same pain that he had previously, or is it a different pain? So all those need to be assessed. And if the pain increases, it may be due to many things. One thing is that is the tumor progressing, and is it causing more compression on nerves and tissues, and is he having more psychological pain? So all those things need to be explored. And it is said that if the patient has no pain relief with 40 milligrams of methadone per day, then you should probably explore the other aspects of pain, like psychological, social, and spiritual aspects. So, for your question, I think I may even increase the dose of methadone because previously he was getting pain relief, and now he doesn't have pain with methadone. So one thing is we can increase the dose of methadone, but you have to explore the other aspects of or other dimensions of suffering. If he is suffering from those, and that is the most common thing which usually patients patients have, and many do not explore it. So I cannot give you a answer that justifies the situation.
What is the role? See, most of the cases what we discussed today were like with neuropathic pain. Role of this neurolytic therapy for this refractory pains when they have gone on maximum dose of morphine or methadone. Still, if patients has like a like the first patient you told they gave a epidural. Well, of course, that is a short because you can't keep the epidural catheter for a long duration. Neurolytic therapies.
Yeah, neurolytic therapy has a role, but I would like to ask you another question. How many patients they can access paying physician to do the neurolytic talk? And what would be the cost of neurolytic talk?
Yeah,
With methadone,
yeah.
the cost is price is very less, and the side effects that's going to occur would also be less compared with neurolytic blocks probably. But if the patient is affordable and if there is a pain physician, there is a role for all the nerve blocks.
Yeah, that's all. Because especially for the neurolytic, this neuropathic complex neuropathic pain syndromes, that we can, yes, they can be offered. Of course, as you told, the availability of interventional pain physician and the facilities at that place, they all matter. But as of this thing, like that can be there on the consideration. for some of those, at least some of those patients who are super refractory to all types of pain relief medications or whatever combination we have tried.
Yeah, I cannot say blindly that all the neuropathic or neurologic drugs are effective, but the select success block for pancreatic pain is
Yeah.
done really in the course of malignancy. There is some evidence that it can be effective, or even it can at least decrease the dose of opioid requirements.
Yeah.
That's something that is we can.
Celiac plexus block, and the first patient what is described with sacral this thing, and the right, she has exclusively right lower limb pain. Pain at rest is also there. So such patients, she can do a selective neurolytic therapy for that side setting, because as per the diagram, it's mostly the posteriorly distributed pain along the sciatic nerve. So if the sciatic nerve can be tackled, then it could be a better or at least provide a better quality of pain relief. That's what my concern is.
Sir, what about methadone and constipation?
So methadone, whenever you start patients on methadone, the constipation would be just like that of morphine. So please provide them with stimulant laxatives.
Is it dose related, or is it or only seen with the higher doses, the constipation when we start?
No, whatever be the opioids, it is not dose dependent. You have to give stimulant laxatives.
Okay, okay, thank you.
Dr. Sunil, since methadone is excreted, it has a bowel excretion. So if patient is grossly constipated, does it affect its excretion, or does it does it really affect the patient in some way?
I do not think because it may not get reabsorbed from the bowel once it is excreted.
Okay, thank you. Thank you.
And somewhere I saw that somebody asked a question about the say pancreas patient where morphine and tramadol used together. So actually, it should not be done because weak opioid need not be prescribed along with a strong opioid. So if you are prescribing morphine, then you need not give tramadol because it's a weaker opioid. But this was given by an oncologist, and when she visited us, that's the prescription.
Thank you, Dr. Sunil, for such an extensive and elaborate presentation. The main thing with this is with methadone, many people may not be aware, one, non-availability, and the amount of experience and things what you have had and you have is a big asset to all of them. See, so many types and patients you have used for, and you would have come across all, like, see, when you use a lot, we do come across many, that's what we say. Someone who sees more patients will see more complications also. So that is what comes hand in hand. So in that way, it was such a big asset to all of you to have had Dr. Sunil take you through, because they effectively use it on a regular basis. Generally, as he mentioned, methadone availability for people who are like weaning them from addiction issues, it is used a lot too. So, but the benefit of it to be used as a pain medication is what the biggest benefit, especially for patients. And see, always everyone will not get benefit with morphine. There will be outliers. That is why medicine is interesting. Okay. So, and then you have to use, and as one question came up, no, like, mom, you start methadone, still not working. That can happen with any drug. So always we say, if you have some issue like that, you think something is not right, stop there, go back to square one, start your assessment, everything from scratch, nothing wrong. Because that is the way you will get satisfaction in yourself that you are dealing with the patient properly. So that is why always review, reassess, review, reassess. That is what always we say, that has two benefits. One is to make sure that the patient gets the best, and it also is a way of assessing your own practice. It's a self-assessment. So I did this is how it has benefited, well and good. Not benefited, what is the reason? Where is it? Somewhere we are missing something somewhere. So that is, so review, reassessment is very, very important. So that will open up cues and clues to you. So you'll be able to solve it. Either it's other form of pain, or maybe sometimes patient, you might have told, take like this, they might not be taking. Something so simple could be there, compliance. So all that, everything is important. Okay, I think I was also going, keeping track on all the questions, and that morphine, tramadol was in my mind, and you have answered. I don't think anything else in the chat has been left. Anybody has anything else which has not been answered, please unmute or let us know. Otherwise, I'll hand it over to Sri Priya. I don't think anything else is on the chat. So over to you, Sri Priya.
Thank you. Thank you, Sunil sir. Thank you so much for enlightening us on such important topics. Because we are sure that this would have been new information for at least some of the participants. Thank you so much for taking out your time and enlightening us. Thank you all the participants for making the sessions very interactive. Yes,
1 minute, Sri Priya. Just I wanted to make sure with the voice and things, no, they were all okay with it, because I felt okay. That's why I didn't, the whole session, everything, the voice, you all could hear Dr. Sunil. So was that okay? Because only one thing, Sri Priya, which came to my mind and I wanted to tell was, if someone is unmuted, you can override and mute them, right? Yes, please do that, because that was one thing I felt a couple of times. So we need not have that disturbance also. Okay.
Sure, ma'am. We do that. Some of the participants particularly does have issues with their devices, and we do mute them. But then when the discussion is going on, we at times get confused whether they have unmuted to interact with the faculty and we are like.
No, that is fine. When the presentation is going on, that is one thing I wanted to tell you, because I didn't want to interrupt in between until, but I thought I'll keep it in mind and let you know at the end. I just keep an eye on that. Otherwise, I didn't feel any disturbance. That's why I kept quiet. Okay.
Sure, ma'am. We'll take more care about that in future.
Only suggestion is,
yes, sir.
Only my suggestion for that, it's better, I think, anybody who wants to interact, raise the hands first, and then that will be a better this thing, rather than barging in between the discussion and this thing. Of course, I myself did that. I'm extremely sorry for that, but I think that will be a more disciplined way of doing it.
Thank you very much. You yourself said the suggestion also. I'm really happy with that. Raising hand and then go ahead. That's very good. See, discipline always gets something good. So nothing wrong. Thank you.
Thank you so much, Dr. Sridhar. A much valid point. Definitely we will take that into consideration and do the needful. Before signing off, tomorrow is National Doctors Day, and we would like to wish every doctor over here an advance happy Doctors Day from the Pallium India team. You are really the real heroes of the lives of many patients, and especially palliative care doctors, because you matter a lot when it comes to pain. So advance happy Doctors Day. Take your time out tomorrow and keep doing this wonderful work. With that positive note, this is Sri Priya along with Dr. Sunil Kumar and Dr. Radha Venkateshan signing off from the Tipsy Cohort. See you in the next session. Till then, everyone, take care. Bye-bye.